Good morning. I'm Sara Monfared. I'm a general surgery resident at Indiana University, and I want to thank SAGES for allowing us to present our research this morning, titled, Do Mandated Weight Loss Goals Prior to Bariatric Surgery Improve Patient Outcomes? I have no financial disclosures. Bariatric surgery remains the most effective and durable treatment for the obesity epidemic. For authorization, patients must meet numerous arbitrary insurance requirements and program-instituted protocols prior to surgery, such as a mandated weight loss. Patients must undergo supervised weight programs required by insurance and by bariatric centers, which usually must be consecutive visits ranging minimum of 3 to 6 months and potentially longer if the program requires preoperative weight loss. So the goal here is to prepare the patient for what's to come and to assess the patient compliance. However, and potentially reduce technical complexity and surgical outcomes and maximize postoperative weight loss. The unintended consequences, however, are meeting specific weight loss goals can further delay surgery from an already required 3 to 6 months and leading to attrition, worsening obesity, and an increased cost. So this is a very busy slide, as this has been a hot topic in bariatric surgery for a while. There has been several studies associating preoperative weight loss to postoperative weight loss with inconsistent data. 2 randomized control trials have seen that there's no association. One has shown a potential association at 1 year. The meta-analysis with systematic review have also been all over the place, with some showing association and others not. Even within our own practice, there's different practices in regards to this topic. So given that it was controversial and continues to be no unified consensus, we decided to look at our institution data. We hypothesized that obese patients who are given weight loss goals prior to bariatric surgery compared with those who are not will have decreased length of hospital stay, increased weight loss at 1 year, and improved resolution of comorbidities. This was a retrospective study from a prospective database that looked at 534 patients who underwent bariatric surgery from January of 2010 to June of 2015. We divided up them into 2 groups based on their initial BMI. If their BMI was from 35 to 45, they were in the no weight loss goal group prior to surgery, and if their BMI was higher than 45, they were given a weight loss goal proportionate to their initial BMI. There was 317 patients in the weight loss goal group and 217 patients in the no weight loss goal group. From this, I'd like to point that all our patients can still require a surgeon visit and psychology evaluation at their initial visit, and also go through supervised weight loss dependent on their insurance requirements with our nutritionist, given a high protein, low carb diet. Comparisons were made between the 2 groups using a t-test for the following parameters: the demographics, length of stay, the preoperative and 12-month postoperative A1C, LDL, systolic and diastolic blood pressure, and percent change in BMI. We also decided to look at the percent excess BMI loss, which was the change in BMI from preoperative to 1 year, divided by the preoperative BMI subtracted by 25, which is the threshold for overweight. So looking at our results, there was no difference in the age between the 2 groups, and the preoperative BMI was statistically significant by the design of our study. We did notice a proportional difference in the type of surgery between the 2 groups. However, in the following results coming up, this was taken into account as a potential confounder in our multivariate analysis. And the length of stay between the 2 groups was exactly the same at 2.7 days. So here, looking at the resolution of comorbidities at 12 months, you can see that cholesterol and blood pressure were exactly the same between the 2 groups. The A1C, while it was significant for the weight loss goal group, having 5.6 compared to 6, when we looked at the difference in A1C from 12 months to preoperative, there was no statistical significance. Looking at the change in BMI at 12 months post-op, there was no difference in percent change in BMI, but interestingly, the percent excess BMI loss was higher in the no goal group at 80% compared to the 60% in the goal group. So from these results, we found that our hypotheses were rejected. Mandated preoperative weight loss did not lead to decreased length of stay, did not improve postoperative weight loss, or lead to better resolution of comorbidities. And surprisingly, the percent excess BMI in the no goal group was higher than the goal group. However, this may just be due to the fact that smaller patients proportionally lose more weight and not necessarily due to the goal setting. There were limitations to our study. It was limited demographics. We didn't include gender, race, or type of insurance, which could have been potential confounders. And this was a retrospective over a short follow-up period. The takeaway points were requiring weight loss prior to surgery did not change outcomes, and an inability to lose a specific amount of weight should not be a barrier to surgery. However, this was over just a 1-year period, and we plan to look at the 5 to 10 year postoperative data. Thank you.
Very nice.